For this lecture, we are going to be talking about pediatrics and how fluid and electrolytes pertain specifically to them. Here you see a little picture that will maybe help you remember normal routes of fluid excretion in infants and children. So when we talk about alteration in fluid and electrolyte status, we're going to be involving the lungs, the skin, and the urine and feces. So thinking back, you remember that regulatory mechanisms for fluid and electrolytes have a big focus on kidneys, the gastrointestinal tract, thermoregulatory mechanisms, and their thirst mechanism. Specifically with kidneys, they regulate the fluid by their ability to concentrate and dilute the urine. So when those sodium levels in their serum are high, ADH is secreted and increases that permeability of the kidney's distal tubules and ducts. Then you have the angiotensin-renin system along with the aldosterone that will assist in regulating the fluids and electrolytes as far as homeostasis goes. When we think about the gastrointestinal tract, water and sodium are reabsorbed and potassium is secreted in the gastrointestinal tract. So fluid is replaced through oral intake, and due to a large surface area of the GI tract, there's that change in the fluid and electrolyte balance that can occur rapidly. We also have the thermoregulatory mechanism, and this is going to come about when we talk about insatiable loss, so that passive water loss through the skin and lungs. And, keep in mind when this happens, there are no electrolytes that are lost. Oftentimes, we think about being thirsty, but keep in mind there is a mechanism behind that. The thirst center is located in the hypothalamus, and thirst is simulated by a decrease in that intravascular volume. So that's why our body says, hey, you're thirsty. Mental and biological variances in pediatric patients. First of all, we'll start with infants. Infants larger than 6 weeks old do not produce any tears, and an infant with a sunken fontanelle may indicate what? Dehydration. Infants are dependent on others to meet their fluids needs. So, if someone's not taking very good care of them, they could definitely have some variances there. And then infants have a limited ability to dilute and concentrate their urine. Some developmental and biological factors are: the smaller the child, the greater the proportion of body water to weight and proportion of extracellular fluid to intracellular fluid there is. Infants have a larger proportional surface of the GI tract than adults. And then infants have a higher metabolic rate than adults. So that's when you see that increased heart rate and increased respiratory rate. Continuing with developmental and biological factors, because of immature kidney function, children lack the ability to adjust the major changes in sodium and other electrolytes. So it's very important to remember that normal urine output is 1 ml per kil per hour. And children are more prone than adults to conditions that affect fluid and electrolyte status, such as diarrhea, vomiting, and high fever. If you ever walk through a cemetery, you'll see late 1800s, early 1900s, there are lots of children buried there compared to adults during that time frame. And that is because we didn't have a lot of knowledge back then about diarrhea, vomiting, and high fever and replacing those fluids. So I just always find that that's an interesting fact. So children have an increase in water needs anytime there's fever, vomiting and diarrhea, diabetes insipidus, burns, shock, especially hypovolemic, and then anytime they are experiencing tachypnea. Decreased water needs come into play anytime a child has congestive heart failure, mechanical ventilation, renal failure, head trauma, and meningitis. With pediatric patients, when we're looking at fluid and electrolyte status, when we're completing that focused health history, it's important to obtain recent fluid intake, including the type of fluid that they ingested and how many times they avoided in the last 12 to 24 hours. And as well as, is there any weight loss or weight gain, and is that recent? When we're completing our focused physical assessment, we want to look at how does the child look? What does their skin look like? What's the temperature? Is the skin dry? What do the mucous membranes look like? Are they dry? Do they have poor skin turgor, tinting, dough-like feel, sunken eyeballs, no tears? Is their skin look, do they look pale, ashen? Are their nail beds cyanotic? Are their mucous membranes dry? What do they look like? Are they pale? Do they look ashen or cyanotic? And then do they have that delayed cap refill of greater than 2 to 3 seconds? Here you see a picture of a child that is severely dehydrated. Sometimes on a child, you need to look at different places to determine the elasticity of their skin. So this picture is showing you that there is a loss of skin elasticity due to dehydration. When we assess their cardiovascular system, you will notice a pulse rate change. Tachycardia is going to be the #1 sign that something is wrong. You see that that's underlined, so that's very, very important. Note the rate and quality. Is it rapid, weak, or thready? Are the pulses bounding, or are there any arrhythmias? The increased heart rate may be the very first sign of hypovolemia, so be on high alert for that. You also want to note any increase or decrease in the blood pressure. So keep in mind that it takes 25% decrease in fluid or fluid volume or blood volume for that change to occur. The respiratory system, you will note there will be a change in the rate or the quality. Dehydration or hypovolemia will show tachypnea, apnea, and deep, shallow respirations, whereas fluid overload, you'll hear moist breath sounds and a cough. Weight is a very accurate way to track fluid, weight loss, and gain. So you want to weigh the child and compare it with previous recent weights if those are available. Keep in mind that substantial fluid loss or gain will be reflected in those weight changes. And 1 gram will equal 1 mil. Weight is the most accurate indicator of a fluid status. And in the hospitalized child, daily weights may be ordered. Diagnostic test. Highly recommended is going to be the sodium, potassium, chloride, BUN, and creatinine. Recommended are calcium, glucose, hemoglobin, hematocrit, and serum osmolarity. And then some optional diagnostic tests are urinalysis, urine sodium, and urine osmolarity. What would a dehydrated patient look like? What is a normal BUN, creatinine, potassium and sodium level? What are those normal levels? Do you remember? If not, you're going to need to look those up, because if you have a dehydrated patient, you are going to see an increase in that BUN, creatinine, sodium, and potassium. And then, what is their hematocrit going to look like if there's something going on? So what are those normal levels? You will need to remember what those normal levels are for your exam. When assessing kidney function, we're looking at the urine output, the specific gravity, the blood urea nitrogen, so that BUN greater than 100 milligrams is going to equal dehydration. With that urine output, you'll see a decrease in that. And with the urine specific gravity, you can see an increase of 1.010 to 1.030. Keep in mind with that blood urea nitrogen, you know, look for those critical levels. If it's above 100 milligrams, it is going to be critical. You can also look at albumin and creatinine to assess that kidney function. Hemoglobin and hematocrit is a very common test that you will see with pediatric patients. When you look at measuring hemoglobin, the main component is erythrocytes. This is the vehicle that transports oxygen. So when there is fluid volume loss, you're going to see an increase in that extracellular fluid pertaining to the hemoglobin and hematocrit. And then when you look at the extracellular fluid volume excess, you'll see that hemoglobin and hematocrit are decreased. Looking at urine-specific gravity, you have your normal values for the neonate is 1.001 to 1.02. And in an infant and a child, it will be 1.010 to 1.020 for the infant, and 1.010 to 1.030 in an older child or an adult. So when you see that the specific gravity is low, that can indicate fluid excess or kidney disease. And when you see that specific gravity is high, that will indicate there is a fluid volume deficit or hypovolemia. We also look at electrolytes. Keep in mind that electrolytes account for approximately 95% of the soluble molecules in body water. We look at sodium. Sodium is the predominant extracellular cation, and then potassium is the predominant extracellular cation. Focusing on sodium, keep in mind that sodium is the most abundant cation and chief base of the blood. The primary function of sodium is to chemically maintain osmotic pressure and acid-base balance. It also transmits those nerve impulses. Normal values for sodium are, does anybody remember? 135 to 148 milliequivalents per liter. Hyponatremia, you will see that the serum levels are going to be less than 130 milliequivalents per liter. Some clinical manifestations that you may see are anorexia, nausea, lethargy, and apathy. More advanced symptoms are disorientation, agitation, irritability, and depressed reflexes. That one's very important for you to know. And then seizures. And then in severe cases, you'll see coma and seizures, and generally that sodium concentration is less than 120. Management principles of sodium can be IV sodium and fluid replacement, restricting that water intake, oral rehydration with commercial fluids, stopping diuretic therapies, and making sure the family is preparing formula correctly. You don't want to over dilute with this. And that is something common. That can be based off of, financial issues or just a knowledge deficit in those caregivers. When we look at hypernatremia, those serum sodium levels are going to exceed 150 milliequivalents per liter. So what do you think that's going to look like? When we look at the primary reasons for sodium excess, a lot of times that can be improperly mixed formula or rehydrated solution, also ingestion of seawater, hypertonic saline IVs, and a high breast milk sodium. A little more in depth. Keep in mind that most infants with severe dehydration are going to have a history of lethargy, listlessness, and a decrease in responsiveness. Those with hypernatremia will tend to be irritable with any stimulation and have a high-pitched cry. With neonatal hypernatremic dehydration, that is associated with breastfeeding malnutrition. Neonates should regain any weight loss within a few days of birth and regain their birth weight by the 10th day of life. That should be a refresher from OB. And then the first signs of neonatal dehydration is going to be failure to have bowel movements and a presence of urine crystals, and then weight loss. Generally, that is greater than 10% of their birth weight. So some management for this is going to be to bring those sodium levels down to normal and restore hydration gradually. This usually happens over 48 hours. And then checking for proper formula preparation to little water mixed with formula. So you're going to be providing lots of education, possibly a lactation consultant if they're experiencing issues with that. And then, keep in mind that you never want to give boiled skim milk. When we look at potassium, potassium is very important. High or low levels can lead to cardiac arrest. With adequate kidney function, excess potassium is excreted in the kidneys. But if the kidneys aren't functioning, the potassium will accumulate in the intravascular fluid. Normal potassium levels. You see that they're slightly different. Adults are 3.5 to 5.3. A child is 3.5 to 5.5. And infants are 3.6 to 5.8. And then, you're probably going to get pretty panicked if it is less than 2.5 or greater than 7. Hypokalemia is defined as a potassium level above 5. Some causes are dehydration or renal disease. Diagnostic tests used to assess potassium are serum potassium levels and ECGs. So with an ECG, you may see bradycardia, heart block, or ventricular fibrillation. Some interventions for hypokalemia would be calcium gluconate, 10% IV to stabilize that cell membrane, and peritoneal dialysis until that kidney function is restored. With hypokalemia, you are going to see low potassium levels. Those potassium levels will be lower than 3.5. So what do we do if potassium is low? We're going to give potassium, right? But make sure before you administer any potassium that the child is producing urine. A child on potassium wasting diuretics is also at risk. And, those examples are things like Lasix. With hypokalemia, you will see neuromuscular manifestations. Those things are neck flop, diminished bowel sounds, truncal weakness, limb weakness, lethargy, and abdominal distension. Or causes of hypokalemia or that low potassium can be vomiting, diarrhea, malnutrition or starvation, stress due to trauma from injury or surgery, gastric suction, intestinal fistulas, potassium wasting diuretics, and an ingestion of large amounts of aspirin. I'm sure in your med-surg courses you remember this. Before administering a potassium supplement, make sure the person is producing urine. This is especially important in children. What are some foods high in potassium? You have things like apricots, bananas, oranges, pomegranates, prunes, baked potatoes with the skin, spinach, tomato, lima beans, squash, milk and yogurt, and then pork, veal, and fish. So anytime you are dealing with clients who have a low potassium level, you may want to look at their cultural practices, food preferences, and things like that. When we can't correct these imbalances via oral administration or oral medications, what is the next step? It's going to be those peripheral IVs. So here you have a diagram showing, again, just reminding where some of those sites are. And, remember, pediatric patients are a lot different. And so, they have those special devices to give when giving fluids to prevent that overload. Interosseous therapy. This happens in an emergency event. So the child is in septic shock or cardiac arrest. They can't get an IV access anywhere else. They're needing to get these emergency medications into the child. So they have to place a needle into the bone. That's what's going on with this. So this is only used for emergency situations. Now we're going to move on and talk about dehydration. Dehydration is a significant depletion of body water. Signs and symptoms include thirst, lethargy, dry mucosa, decreased urine output, and as the degree of that dehydration progresses, you'll see tachycardia, hypotension, and shock. Causes of dehydration. The most common cause is fluid loss in the GI tract from vomiting, diarrhea, or both. It can also be related to hypovolemic shock. This is the second most common cause of cardiac arrest in infants and children. So you have that loss of fluids and you have that loss of fluid volume. When looking at dehydration, the most common cause of dehydration in infants and children is the rotavirus. Keep in mind that the World Health Organization recommends immunization against the rotavirus to decrease those infant deaths worldwide. And again, if you go back and you look at cemeteries or you look at countries who have a lot of poverty levels, you will see that a lot of children die from this. Looking at dehydration and the clinical signs and symptoms of dehydration. You've got the loss of body weight, and then you have the severity. So whether it be mild, moderate, or severe, and kind of what those look like. What does their level of consciousness look like in each of those severity levels? What does their blood pressure look like? Their heart rate, pulse, mucous membranes, their eyeballs, their fontanelles, their skin turgor, their skin temperature, and their urine output. So make sure that you take time to pause the presentation and look over these things. For mild to moderate dehydration, the first line is going to be oral rehydration therapy. So you start out with 50 mils per kilogram every 4 hours, and then you want to increase that to 100 mils per kilogram every 4 hours. You don't want any carbonated soda, jello, fruit juices, or tea. You want to focus on commercially prepared solutions. Those are the best. Those are going to have the components that the child needs as far as fluid and electrolytes. When we look at rehydration therapy, keep in mind you want to increase PO fluids if they have diarrhea, and that increases. You want to give those PO fluids slowly if they're vomiting, and you want to stop oral rehydration therapy when hydration status is normal. You don't want to get them into fluid overload. And then, most likely their stomach's going to be upset, and so you're going to start them on a brat diet. That consists of bananas, rice, applesauce, and toast. So if you think about the nutritional components of those 4 things, you can see why that brat diet is started. Those are also very bland type foods. How you can mix a solution for these children. Dehydration and diarrhea, those kind of go hand in hand, right? So some teaching and parent instruction that you will need to do is when to call that primary care provider. And you want to encourage them to call them if the diarrhea or the vomiting increases, there's no improvement seen in the child's hydration status, the child appears worse, the child won't take any fluids, and no urine output. That's a huge one. So keep in mind, these guys are littler. Their body just does not do well if they are not hydrated properly, and this situation can go from mild to extreme in no time, just because of their body system and how it functions at a younger age. When a child needs IV therapy, that is going to be going on when they have moderate to severe dehydration. With fluid resuscitation, you're going to be using a crystalloid solution, and it's used for volume resuscitation to expand that interstitial volume rather than the plasma volume. Those isotonic saline solutions are the prototype crystalloid fluid. So you've got 9% normal saline chloride or normal saline. With fluid replacement, you have some standard orders listed here. You've got that normal saline or that 9% at 20 mils per kilogram. Generally, that's followed by dextrose 5% in 0.45 normal saline, followed by dextrose 5% in 0.45 normal saline with 20 milliequivalents of potassium per 100 mils. Potassium is only added to the IV when there is documentation of voiding. That's very, very important for you to remember. Nursing interventions with this is to assess the child's hydration status. You're going to be looking at vital signs with temperature and weight. That is the most accurate way to monitor those fluid levels. You've got that hourly monitoring of the IV rate and the site of infusion. You're also going to be looking at their INOs. Something that I want you to remember is a severely dehydrated child will need more than maintenance to replace lost fluids. So you've got 1.5 to 2 times the maintenance. And it's the nurse's responsibility to check those fluid calculations at the beginning of the shift. 24-hour fluids needed hourly, and what that IV rate is going to look like. It is your responsibility as the nurse to do these things. You want to keep these children safe, right? You want to give them enough, but you don't want to give them too little or too much. Giving too much hydration can cause overhydration. That is going to occur when they receive more IV fluids that's needed for the maintenance. In pre-existing conditions such as meningitis, head trauma, kidney shutdown, nephrotic syndrome, congestive heart failure, or pulmonary congestion, you can see this overhydration happen very quickly. Some signs that you will look for when assessing for overhydration is tachypnea, dyspnea, cough, moist breath sounds, weight gain from edema, and jugular vein distension. If you notice some of these symptoms, and essentially all of them are the same as with overhydration in an adult patient. However, with children, weight gain is going to be a big thing that you will notice. Safety precautions when providing hydration for children. You want to make sure that you use small bags of fluid or the Buretrol to control that fluid volume. You want to be checking that IV solution infusion against those physician orders. You always use an infusion pump so that the rate can be programmed and monitored. And then be sure that you're calculating those 24-hour fluid needs. Do that every single shift change. And then record that IV rate every single hour. That shows that you are monitoring and keeping your pediatric patients safe. Now we're going to look at acid-base imbalances. This should just be a refresher from what you learned in your med-surg courses. You have acidosis, looking at respiratory acidosis. If you remember, this is when there is too much carbonic acid in the body. And then with metabolic acidosis, this is when there is too much metabolic acid. Then moving on to alkalosis. When we think about respiratory alkalosis, this is where there is too little carbonic acid. And then with metabolic alkalosis, this is where you have too little metabolic acid in the system. When discussing respiratory acidosis, keep in mind that carbonic acid excess is going to be when you have the CO2 retained and the pH decreases. This is caused by an accumulation of carbon dioxide in the blood. Acute respiratory acidosis can lead to tachycardia and cardiac arrhythmias. Some causes of respiratory acidosis is any factor that interferes with the ability of the lungs to excrete carbon dioxide. Those things can cause respiratory acidosis. And then you have aspiration or a spasm of the airway, laryngeal edema, epiglottitis, croup, pulmonary edema, cystic fibrosis, and bronchiopulmonary dysplasia. We've talked about several of those things. You also will see it with a sedation overdose, a head injury, or sleep apnea. When doing your assessment, you're going to look for respiratory distress. Is there any CNS depression such as disorientation or coma? What about hypoxemia? What does that look like? Restlessness, irritability, tachycardia, arrhythmias, and then you're going to be looking for muscle weakness. For respiratory acidosis is going to consist of correcting the underlying cause. You also may be giving bronchodilators, especially if they have asthma, antibiotics for infection, mechanical ventilation may be seen, and decreasing that sedative use. Respiratory alkalosis. This can be related to a carbonic acid deficit. So there's not enough CO2 that's retained and the pH increases. You have excess carbon dioxide loss, which is caused by hyperventilation. What are some causes of hyperventilation? This should be a refresher for you. So things like hypoxemia, anxiety, pain, fever, aspirin poisoning, meningitis, and overventilation. When doing an assessment, you may see dizziness, numbness, or paresthesias of the fingers and toes, tetany, convulsions, or even unconsciousness. How do we manage respiratory alkalosis? So we're looking at stress management if it's caused by hyperventilation, pain control, adjust the ventilation rate, treat the underlying disease process, and have the child slow their respirations by breathing into a paper bag. Hopefully you remember that a metabolic acidosis is a bicarbonate deficit. So let's look at that a little more. Causes of metabolic acidosis. Number one could be a gain in acid, so ingestion of those acids, oliguria, starvation or anorexia, diabetic ketoacidosis or DKA, and tissue hypoxemia. And number two, it could be related to a loss of that bicarbonate, and that could be from diarrhea, an intestinal or pancreatic fistula, or renal anomaly. If a patient has metabolic acidosis, some assessment findings that you will see are those Kussmaul respirations. They're slow and they're deep. Shortness of breath on exertion, weakness, drowsiness to stupor, and when that pH is less than 7.2, the cardiac contractility is reduced, so their blood pressure will decrease as well. How do we manage metabolic acidosis? First of all, we're going to want to treat and identify that underlying cause. They can have an IV sodium bicarbonate in some severe cases. You want to provide low protein, high calorie diet and a position to help facilitate that ventilation, making it easier for them to breathe. When thinking about metabolic alkalosis, you should remember that this is where you see a gain in a bicarbonate or a loss of metabolic acid. And this is what leads to the metabolic alkalosis. So we have a couple of causes. It can be related to, again, that gain in bicarbonate. So like ingesting baking soda or acids. Maybe a child gets into the cabinet, gets the baking soda, or finds the Tums. They think they taste super yummy and eat a bunch of them because they look like candy, maybe taste like candy. And then it could also be caused from a loss of acid. So that's going to be related to like vomiting or nasogastric suctioning, diuretics, or like a massive blood transfusion. When assessing those pediatric patients that have metabolic alkalosis, it's going to be pretty similar to dehydration. You're going to see that tachycardia, hypoventilation, muscle hypertonicity, confusion, irritability, and then coma. Treatment for metabolic alkalosis is going to be administered fluid containing sodium and potassium. Avoid those antacids. And, as far as management goes, you also want to be correcting the underlying condition. This concludes our presentation. But I want you to be sure and go back and review some of the documents in the course pertaining to ABGs and how you determine by looking at those ABGs what state they are in, whether it is respiratory or metabolic, is it alkalosis, is it acidosis, is it mixed? So make sure you're going back and reviewing all of that information in those documents.